Welcome to our third and last video on tachyarrhythmias. Let's begin. In this last lecture, we'll cover ventricular tachycardia and ventricular fibrillation. Let's get started. We'll talk about the definition, etiology, pathophysiology, diagnosis, and management of ventricular tachycardia. Ventricular tachycardia is characterized by a heart rate of 100 beats per minute or higher and a 3 or more consecutive beats of ventricular origin. The beats of ventricular origin appear on ECG as wide QRS complexes. Ventricular tachycardia can be classified based on its duration and morphology. Let's begin with duration. A patient is said to be in sustained VT when this abnormal rhythm lasts for 30 seconds or more or causes hemodynamic instability. On the other hand, non-sustained VT is when this rhythm lasts for less than 30 seconds. Regarding the morphology, VT is called monomorphic when all the QRS complexes have similar morphologies, whereas it is called polymorphic simply when VT has different QRS morphologies. A common special subtype of this is the torsades de pointes. Let's look at the various etiologies of ventricular tachycardia. Ischemic heart disease and non-ischemic cardiomyopathies like hypertrophic cardiomyopathy can lead to ventricular tachycardia. Ischemic heart disease could be due to cardiac scar from prior myocardial infarction or surgery, or it could be due to chronic angina. Genetic causes that result in ion channel mutations, such as long QT syndromes and Brugada syndrome, can also lead to ventricular tachycardia. Medications also have been shown to trigger VT, and examples are amiodarone, sotalol, digoxin toxicity. Lastly, hypokalemia, hypomagnesemia, hypocalcemia are some electrolyte imbalances that can cause VT. Ventricular tachycardia can be caused by several factors, but the main mechanism involves abnormal ventricular activation and depolarization. This can be due to increased automaticity from an ectopic foci in the ventricles. It can also be from a re-entry circuit within the ventricles, most commonly in cases of scarring, post-myocardial ischemia, or surgery. These two mechanisms typically give rise to VT with QRS complexes of similar morphology. On the other hand, polymorphic VT is associated with multiple ventricular ectopic foci that have increased automaticity. In ventricular tachycardia, there is dyssynchrony between atrial and ventricular contractions. This leads to reduced blood flow from the atria to the ventricle, thus decreased ventricular filling. In turn, this results in decreased cardiac output, and the patient presents with features of hemodynamic insufficiency such as syncope, dizziness, and chest pain. Ventricular tachycardia is an ECG diagnosis. The rate is usually tachycardic, 100 or more beats per minute. The rhythm is usually regular if VT is monomorphic, while it is irregular in polymorphic VT. The patients have a wide QRS complex due to ventricular origin of the arrhythmia. There may be signs of dissociation between atrial and ventricular activity. This is seen when the P waves are dissociated from the QRS complexes and maybe even hidden within them. Occasionally, an impulse can travel from the atria and meet with the impulse from the ectopic ventricular foci, causing something called a fusion beat. This usually has a mixed morphology of a normal sinus QRS complex and a QRS complex of ventricular origin. Capture beats occur when a normal QRS complex interrupts the wide complex tachycardia, and this is due to the occasional conduction of the atrial activity by the AV node. While an ECG is required for diagnosis acutely, imaging studies such as echocardiography need to be performed to identify the underlying cause of the ventricular tachycardia. Commonly, lab tests of electrolyte levels such as magnesium, potassium, and calcium are also useful. Ventricular tachycardia can often degenerate into life-threatening ventricular fibrillation. This ECG shows monomorphic ventricular tachycardia. Wide QRS complexes can be seen throughout the ECG, which is a QRS duration greater than 120 milliseconds. QRS complexes all have similar shape. P waves are buried within QRS complexes. This ECG shows torsades de pointes. Twisting around the isoelectric line can be observed, giving rise to a sinusoidal pattern. This can be difficult to differentiate from a ventricular fibrillation sometimes. The first step in assessing a patient with ventricular tachycardia is to check if they are hemodynamically stable or not. If the patient is hemodynamically unstable, we check for a pulse. When there is no pulse, the patient has pulseless VT, which needs immediate CPR and defibrillation based on the advanced cardiac life support algorithm. However, if the patient is unstable but has a pulse, the next step is to determine if it is polymorphic or monomorphic VT on ECG. In polymorphic VT, we defibrillate the patient, but in monomorphic VT, we do synchronized cardioversion. If there is uncertainty regarding the morphology of VT, we defibrillate the patient. Stable patients can be converted to normal sinus rhythm using antiarrhythmic medications. Procainamide is used if there is no prolonged QT interval, and amiodarone if there is a prolonged QT interval or risk of prolonging the QT interval. For torsades de pointes, we administer magnesium sulfate. The first line, pharmacotherapy for long-term control of ventricular tachycardia, are beta blockers such as propranolol, metoprolol, or carvedilol. These are used in patients with VT in order to prevent sudden cardiac death. Implantable cardioverter defibrillator can be used as another means to prevent sudden cardiac death in high-risk patients with recurrent uncontrolled VT, despite optimal therapy. A 72-year-old woman is brought to the emergency department due to palpitations and confusion for the past 30 minutes. Her vital signs include a blood pressure of 80/60 and a heart rate of 140 beats per minute. ECG shows wide QRS complexes with alternating incremental and decremental amplitudes. Which medication should promptly be administered to this patient? This woman presents with palpitations and confusion for the past 30 minutes. Her vital signs indicate hypotension with a blood pressure of 80/60 and tachycardia with a heart rate of 140 beats per minute. ECG shows wide QRS complexes with alternating incremental and decremental amplitudes. This is a classic description of torsades de pointes, a subtype of polymorphic ventricular tachycardia. The medication that should be promptly administered to the patient with torsades de pointes is magnesium sulfate. Magnesium sulfate can terminate this arrhythmia. Lastly, we will talk about ventricular fibrillation. We will discuss definition, etiology, pathophysiology, diagnosis, and management of ventricular fibrillation. Ventricular fibrillation is a life-threatening arrhythmia that is the result of disorganized and chaotic electrical activity within the ventricles. It is similar to what happens in the atria during atrial fibrillation, but more serious given that synchronized ventricular contraction is necessary to maintain cardiac output. Ventricular fibrillation is the most common arrhythmia to occur in the first 24 hours of a myocardial infarction and is hence the leading cause of death before the patient arrives to the hospital. While VF can arise on its own, most are preceded by ventricular tachycardia. Ventricular fibrillation can have many underlying causes, but the most common one is ischemic heart disease. Other causes that can precipitate VF include non-ischemic cardiomyopathies, long QT syndrome, Wolff-Parkinson-White syndrome, and electrolyte disturbances like hypo and hyperkalemia. Let's talk about the pathophysiology. In ventricular fibrillation, there are re-entry circuits that can result from the presence of a scar tissue after an ischemic heart disease. The abnormal conduction due to these circuits leads to disorganized myocardial activation and chaotic contractions at multiple foci. This is characterized by fibrillatory contractions of the ventricles, which are inadequate to maintain a normal cardiac output. This eventually causes hemodynamic collapse, which in turn leads to syncope or sudden death. In patients with VF, ECG often shows a very chaotic electrical activity. There is a rhythmic fibrillatory baseline with no discernible QRS complexes or P waves. The rate is often greater than 300 beats per minute. Adjunctive studies such as echocardiography, coronary angiography, electrolyte panels, and serum TSH can be used to identify the underlying etiology. This ECG of ventricular fibrillation shows no clear QRS complexes or P waves and no normal isoelectric baseline. There is generalized chaotic electrical activity. Here is the ACLS algorithm for the management of ventricular fibrillation and pulseless ventricular tachycardia. In patients with recognized ventricular fibrillation or pulseless ventricular tachycardia, the initial step is to begin cardiopulmonary resuscitation and gain intravenous or intraosseous access. Patients should be defibrillated as soon as possible. We reassess pulse and rhythm after defibrillation or after 2 minutes of CPR. If there is return of spontaneous circulation, then we continue with post-resuscitative care, which includes treating the underlying disease, managing blood pressure and airway, and maintaining constant temperature. If there is no return of spontaneous circulation and the rhythm is still VFib or pulseless VTAC, patients should be defibrillated for a second time. This should be followed by CPR for 2 minutes and epinephrine every 3 to 5 minutes after the second shock. Amiodarone can be given after third shock. We may continue intubation if that is applicable. Here's a table that summarizes the main features of all tachyarrhythmias we discussed throughout all 3 lectures. Pause the video and take a moment to consider this table. This algorithm will allow for an easy recap of most tachyarrhythmias. Regarding the narrow complex tachyarrhythmias, which have a regular rhythm, we can further look at the presence of P waves for differentiation. If there are P waves, then it is sinus tachycardia. If there are no P waves, and there is a presence of a sawtooth pattern on ECG, it will be classified as atrial flutter. Otherwise, it will be supraventricular tachycardia. Among narrow complex tachyarrhythmias with an irregular rhythm, the presence of distinctive P waves will be classified as multifocal atrial tachycardia, and the absence of P waves will be classified as atrial fibrillation. Wide, complex tachyarrhythmia with a regular rhythm is likely ventricular tachycardia. If there is an irregular rhythm, then the presence of a sinusoidal pattern indicates torsades de pointes or polymorphic ventricular tachycardia. In the absence of any discernible pattern, the wide, complex, irregular tachyarrhythmia will be classified as ventricular fibrillation. Let's end our lecture with a board-style question. A 75-year-old man is brought unconscious to the emergency department after suddenly collapsing at the hospital entrance 5 minutes ago. His past medical history includes poorly controlled type 2 diabetes, mellitus, hypertension, and 2 episodes of myocardial infarction. He is pulseless and is not breathing. Cardiopulmonary resuscitation is started immediately. ECG shows irregular rhythm with no discernible waves. Which of the following is the best next step in the management of this patient? A. Synchronized cardioversion, B. Unsynchronized cardioversion, or C. Epinephrine, or D. Amiodarone. This elderly man is brought unconscious to the emergency department after suddenly collapsing at the hospital entrance 5 minutes ago. He is pulseless and not breathing, indicating cardiorespiratory arrest. Cardiopulmonary resuscitation is started immediately. ECG shows irregular rhythm with no discernible waves. This pattern confirms ventricular fibrillation. Since ventricular fibrillation is a shockable rhythm, the best next step in the management of this patient is unsynchronized cardioversion, also known as defibrillation. So correct answer is option B. Here's a slide reminding us of the management of ventricular fibrillation. Pause the video and take a moment to consider this slide again. Let's discuss why other options are incorrect. Option A is incorrect because it is impossible to perform synchronized cardioversion in patient with ventricular fibrillation. Synchronized cardioversion targets the QRS complexes in order to deliver shock. In contrast, the patient with ventricular fibrillation has no discernible QRS complexes on ECG. Option C is incorrect because epinephrine is given to the patient with ventricular fibrillation after second cycle of unsynchronized cardioversion. Option D is incorrect because amiodarone is given to the patient with ventricular fibrillation after third cycle of unsynchronized cardioversion. And that concludes our lecture on tachyarrhythmias.